patient to do is pretend like there's a dollar bill between their cheeks and to squeeze their cheeks together as hard as they can. So when I say squeeze, I want you to squeeze your cheeks together, okay? Squeeze. She squeezes. Once she squeezes, I have her relax. I simply put my fist in there and say squeeze and relax, squeeze and relax. Or I can use my fingers. Patients tend to be a little bit more squeamish about this technique, feeling their buttocks in that way. So a lot of times in the clinic, the therapist will use their fists. 2, now, deep to the gluteus maximus is the piriformis. Our landmarks that we'll be using will be the sacrum. We know how to find the L4, L5 interspace to find the sacrum. We know how to come off the edge of the iliac crest to find the greater trochanter. And we know that the piriformis comes from the anterior surface of the sacrum and goes to the tip or top or crest of the greater trochanter. So we know that it goes in this direction, but it's deep to the gluteus maximus. So the motion that we're going to be using is we are going to be resisting hip external rotation because it is the primary external rotator. External rotation is when she takes her foot and brings it inward. That is external rotation of the femur. This can be confusing when the patient is prone. So I'm going to be resisting this motion. So I'm going to be pushing her in that direction. She is going to be trying to push in this direction. Once I find my landmarks, I know that it's in this area. If you do not palpate this particular muscle well, do not be disheartened. Most of the time, it is hard to palpate if it is normal. In the clinic, when the patient has a spasming piriformis, it sticks out like a sore thumb and it is extremely tender. Otherwise, this is not tender for the patient. It is not painful for the patient in any way. All right, do not let me move you, and I resist, and the piriformis runs in this direction, so I'm trying to strun the muscle across or perpendicular to the muscle fibers, and relax. And contract, don't let me move you, and relax. And don't let me move you, and relax. Again, if you cannot feel this muscle, do not be disheartened. It sticks out like a sore thumb if there is pathology, and that's the only time we're going to be treating it anyway. The last muscle in the prone position will be the common hamstring tendons. All of the hamstrings come up and insert onto the ischial tuberosity. We've already gone on how to palpate the ischial tuberosity, so we come up and find the ischial tuberosity. Simply come to that ischial tuberosity. We will flex the patient's leg up, and we are going to resist them performing knee flexion. So I find ischial tuberosity, come just distal to that ischial tuberosity, pushing into the soft tissue. Say to the patient, don't let me move you. And then I can feel a huge, huge, thick, it's probably as thick as those 3 fingers, tendon when she contracts her hamstrings. Don't let me move you. And it is a huge tendon right there. Don't let me move you. It pops up right there.